Baylor Uganda has been the lead implementer of this program, and Baylor Uganda is funded by CDC, which gave us a platform to roll out and start this program. We work together with PayPal, bringing in the support in coordination and planning, and as usual, our role is to support the Ministry of Health to strengthen the system at hand. So with this, we had technical support coming in from Janssen, who bring on the corporate expertise, and this was all made a success with funding from Comic Relief, who have been able to fund this 3 years intervention. So briefly, I'll take you through what we're able to achieve. I think you can move the slides. It's not moving. We had the mission to empower all health facilities to deliver high-quality services through a comprehensive district mentorship program. It is district-led because, as you've heard, the mentors were selected working hand-in-hand with the district health officers and the district leadership so that we can have ownership and sustainability of this program. And this was to address the operational leadership gaps among the frontline health workers and also looking at issues they face while at work. And our vision was to have an empowered, motivated, and accountable frontline, which is able to adapt to the skills and also the challenges in the under-resourced environment which they could be operating in. So we had 4 objectives that we are working with, and our objectives focused on 4 main areas. The first main area was to build the leadership and motivational skills. This is where we have the trainings taking place, the mentorships taking place at health facility level. Then the second was to empower health facilities to have basic facilities that are functional, and this is where we looked at issues such as tracking lateness, attendance to duty, and also having regular monthly meetings where information and data can be shared. Then we believe that with all these skills and functionality, we would be able to increase on the way services are being utilized among the key people that come to access. Here we look at issues such as increase in accessibility by the pregnant mothers, but also by the outpatients that are able to receive the services. Then the fourth objective is where we are now, and this one is to focus on how we can use the evidence and generate lessons learned and see how we can influence policy and also look at scale up in the areas of intervention. The program was implemented in 2 main regions. We had the Eastern region and Rwenzori region, and in total we had 16 districts that we are serving. And of all these districts, we are reaching a total of about 270 health facilities. So we now look at the numbers that are behind this program. First, like I had said, we have the health workers. These are the mentors that we are talking about. We have a team of 83 mentors who are health workers, and the people that you see here is just a small representation because we couldn't manage to get all of them available here. So these mentors were trained to go and be able to reach a total of 270 health facilities. And you find on an average, each mentor is given 4 to 3 health facilities where he goes on a quarterly basis to conduct a mentorship and take health workers through basic leadership modules. In total, they reached over 5,000 health workers, and like you heard from the previous speakers, that everyone is a leader. When they go to the health facility, they look at every health worker that is available and all health facility staff, right away from the people who clean the facilities to the security guards up to the in charge of the facility. Because once the person responsible for cleaning does not do his role, however much a clinical practitioner you are, you may not work in a conducive environment. And once the person with security does not keep the stores well, the patients will never access drugs in their quantities as they may end up being misused. So we took everyone as a leader, and that's how they reached a total of about 270 facilities. Then the total catchment population of all the 16 districts was totaled to about 4.4 million people, and here we had a total population of about 200,000 expectant mothers who were accessing quality services that are being delivered. This is an example of a session being delivered by the mentors at a health facility, and what you see here is the uniqueness of the flexibility that happens within this program. It's flexible because it can be done at any point. You don't necessarily have to take healthcare workers to a hotel and out of their session to deliver a training program. And this brings them on site, and also you as a trainer, you are able to see and appreciate the challenges they face at work, which makes the training participatory and effective. These are some of the modules that were taken through the mentors. At the beginning, we looked at issues of time management, communication, and issues of teamwork. But the rest of the 6 modules have been developed through continuous learning and sharing. When you go to a facility and you find that conflicts are the main challenge, a module in conflict management was introduced and mentors taken through this. Together with issues of situational leadership, whereby people are not trained as health facility managers, but when you go to a facility, you are expected to manage and lead a team of people with different skills. So without situational leadership to adapt to that situation, it becomes challenging. So these are some of the modules that the people were taken through. And again, from each module, we did not stop at delivering the training. We worked with the mentors to see how can we develop a sustainable tool that can be used. Each module had a tool to promote continued usage and adaptability. I'll briefly talk about the team performance monitoring tool that is in the extreme up corner there. This is very good at decision making and also use of data in planning. The meeting book has played a key role in increasing the number of facilities that are having the monthly meetings. And when we go to the results that we have been able to observe in a short while, you will see that each module directly contributed to the results that we see. This is a snapshot of the high-level results because we have a session tomorrow to look at all these results in detail. But to briefly take you through, from tracking lateness, we had an increase in 57% from facilities that are able to track lateness. This is the gateway to address absenteeism and attendance to duty. From tracking lateness, we had a number of staff arriving late reduced to about 27%. And this directly corresponds with a reduction in the waiting time that patients spend before they access the services. And from the surveys that are conducted where patients are interviewed on how they perceive the quality of care, we have seen an increase in their satisfaction. And from this, we can see that most of them are willing to return access services, willing to recommend similar services to their colleagues, and we use this as a proxy to show that there is increased quality of service provision in the services that are being offered. So in brief, that is a snapshot and in summary about the program that I was able to share with you, and we shall discuss more relating to how the results came out in detail in a later session. Thank you very much.